Welcome, everyone. On behalf of React 19, I would like to introduce Dr. Joseph Colombo. We are very lucky to have him with us today. Dr. Colombo is trained in neurology with a background in electrical and mechanical engineering. His focus is neurocardiology. He has his MD and obtained his PhD from the University of Rochester in neuroscience and biomedical engineering. Dr. Colombo currently serves as Chief Technical Officer and Senior Medical Director of Physio PS Inc. He is also the Parasympathetic and Sympathetic Nervous System Consultant at Franklin Cardiovascular Associates in Pennsylvania. He is in Jersey. Okay, sorry. He is also licensed as a Doctor of Natural Medicine and a Doctor of Humanitarian Services. Dr. Colombo has been an adjunct professor in medicine and lectures worldwide on disorders and treatments of the parasympathetic and sympathetic nervous systems. He has had a prolific career and has published over 100 papers as well as many textbooks and chapters. Please welcome Dr. Colombo.
Thank you, and good evening. Before we start, if anybody would like to have any discussions with me offline or seek medical services that we might be able to refer them to, if you would please go to the website physiops.com. There's a patient portal where you can provide us your contact information and somebody will get back to you with hopefully answers to your questions or possible solutions to whatever your problem might be. So tonight we're going to be talking about parasympathetic and sympathetic nervous system and COVID-19, both including the virus, the vaccine, and long COVID. So we'll talk about what viruses do, including vaccines, have a brief review of the parasympathetic and sympathetic nervous systems so that we are all on the same page, talk about long COVID and the parasympathetic and sympathetic symptoms that it causes, the treatments to normalize PNS function and balance, and then talk about possible flares and setbacks caused by stressors. So to start with, make sure that we all understand, as we're taught in medical school, that all viruses do at least two things. They hijack your DNA to replicate, and they plunder the mitochondria of your ATP in order to fuel that replication. Understand that all nerve cells, including brain cells, have some of the highest concentrations of mitochondria of all the cells in the body. The average nerve cell is known to have approximately 2 million mitochondria per cell. So viral plundering of the mitochondria not only promotes oxidative stress, but exacerbates it. Your mitochondria are not the most perfect things, just like any power plant on Earth. So they're not 100% efficient. And any further decrease in that efficiency is what causes the fatigue and flu-like symptoms if it's mild, and can create all the neurological issues and many other issues that are known to occur for more severe infections, etc. And we'll get into some of that. Oxidative stress is highly toxic to nerves, as I just suggested, and autonomic monitoring the parasympathetic and sympathetic nervous systems actually helps to identify morbidity and mortality risks, which is usually key to whether or not your reaction to COVID is mild, moderate, or severe. So advanced autonomic dysfunction, which is also known as diabetic autonomic neuropathy, if you're diabetic, indicates morbidity risk because it indicates that more systems will begin to become abnormal. The nervous system is beginning to weaken and not able to control these organ systems appropriately. And then eventually late stage autonomic dysfunction is called cardiovascular autonomic neuropathy, which indicates mortality risk and risk of heart attack, stroke, and other ICU type events. So from a COVID point of view, whether it's vaccine injury or the virus itself, if your autonomic function is within normal limits, typically at worst, the injury is a flu-like symptom. Whereas if you have advanced autonomic dysfunction and high morbidity risk, you might wind up seeing the inside of the hospital, but you'll walk out as if nothing happened eventually, like a severe flu response. If your mortality risk is high, these are the folks that wind up in the ICU and are at risk for, are at risk for more severe symptoms. So as we've recommended to many of our patients over the years, if they're afraid of what the vaccine might do to them, and they have to take the vaccine for whatever reason, job or whatever, high dose antioxidants and the stronger antioxidants, not the ones that are typically recommended like zinc, and high dose anti-inflammatories actually help to minimize the risk because they'll help to minimize oxidative stress and help keep the mitochondria healthy, which gives your nerves a chance to help fight off the virus. So all vaccines produce pathogens, either the virus itself or parts of the virus, the proteins, for the body to remember. The parasympathetic nervous system, which is going to become key to a lot of this, is this portion of the nervous system that actually provides the memory for the immune system and the controls and coordinates the immune system. As a medical and PhD student, I had the privilege of one of my thesis advisors being the gentleman that actually first discovered a nerve synapse on an immune cell and proved that the parasympathetic nervous system does indeed provide the memory and control and coordination for the immune system. So, and then in response to the vaccine, the immune system is supposed to be mildly activated. But if your parasympathetics are already overactive, what we call parasympathetic excess, then the immune system is going to be overactive and you're going to have a full-on response. And this is the result of vaccine injury, just as if the full infection was received. And it turns out vaccine injury from our point of view is just simply long COVID. Well, not simply, but it is long COVID. So a quick review of the autonomic nervous system. The parasympathetics involve mostly the vagus nerve, as well as sacral nerves that control organs at the floor of the pelvis. It's considered the rest and digest nervous system, but we also think of it as the protective nervous system, and I'll get into that in a minute. It's primarily a cholinergic system. It's the faster of the two systems to respond. It sets the threshold around which the rest of the autonomic nervous system responds. And we use the model of the car, brakes and accelerator. The model for that we're taught in medical school is the seesaw. Well, the seesaw is inherent in the brake and accelerator model, right? This is an automatic car, not a manual transmission. So when you're at rest or when you're driving normally, you're either on the brakes or on the accelerator. There's your seesaw. The problem is the seesaw only works when you're resting or when you're normal. We don't see too many normal patients, and this portion of the nervous system is rarely resting. So the seesaw model doesn't do a very good job of describing what's going on very well. And we'll get back to the brake and accelerator model of the car in describing long COVID in a few minutes here. The sympathetics actually have two branches, the alpha sympathetics, which control the vascular outside, the thoracic cavity, and the beta branch, which controls the heart and the lungs and everything inside the thoracic cavity, basically. It's, as we know, is the fight or flight response. It's based on adrenaline. It's slower to respond. And if we use the car model, you never want your accelerator responding faster than your brakes, or you may never stop, right? So the body is very similar to that. That's why it's slower to respond. It speeds things up generally, but it's slower to respond. whereas the parasympathetics, which slow things down generally, is faster to respond. And that makes sense if you think of the brakes and accelerator of your car again. The sympathetics are the reactionary system. It's supposed to be normally short acting. And that's the reason why a lot of adrenaline laying around the body is not a good thing. And this stress-filled, fear-filled environment, that society that we live in, is usually a significant reason for a lot of the sympathetically mediated dysfunctions that we know about. And again, it's like the accelerator on a car. So, quick review of the parasympathetic and sympathetic nervous systems, and we'll be using this throughout the lecture. So from the point of view of needing to measure both the parasympathetic and sympathetic nervous systems at the same time, but independently of each other, not just the total autonomic system, as well as from a point of view of understanding better what's going on as far as COVID, vaccine injury, and long COVID is concerned, we use the thermostat analogy. So the thermostat is in your house, maybe set to 70 degrees Fahrenheit. Sorry for the international folks, but the analogy works better, like 70 beats per minute for your heart. And let's say you have a separate cooling system and a separate heating system. Heating system like your sympathetics, the cooling system like your parasympathetics. So as long as the two are working together in a coordinated fashion, no matter what the heat or what the temperature outside is like, it'll keep your house at 70. And as long as your house is 70, everybody is fine. So, but let's pause there for a moment. The parasympathetic monitoring, in order to get an independent and simultaneous, and independence is a mathematical independence. In order to get a mathematically independent and simultaneous measure of the parasympathetic and sympathetic nervous systems, you have to have two measures of a two-component system. The problem with most autonomic measures that are out there is they're only measuring one component, the EKG. The heart is only one measure. I don't care how you slice and dice the data you get from the heart. You get the EKG, you can go to heart rate variability, you can go to beat-to-beat blood pressure, but those are measures of two inputs to the heart, right? The heart has both the parasympathetic and sympathetic systems controlling it at all times. So if you're only measuring the heart, you're still guessing as to what the two components are doing. So total autonomic measures are mathematically incomplete. Parasympathetic and sympathetic measures are mathematically complete. As a result, the parasympathetic and sympathetic measures, as listed on the left, results in specific PNS activities. It's quantitative results and enables follow-up testing, so we can see how the patient's responding to therapy or changes in the disease state. As opposed to, on the right-hand side, total autonomic measures, which give you only qualitative results, relative parasympathetic and sympathetic changes, forcing approximations and assumptions to specify or hypothesize what's going on with one branch or another. This is part of the reason why in most cases, autonomic dysfunction has to get pretty severe before any of the autonomic experts can actually do anything for you, because their general assumption is the sympathetics are much more active than the parasympathetics. And usually that's the case. That's not a bad assumption. The problem is, what are they going to do? They're going to treat the sympathetic side. And once you treat the sympathetic side, you reduce the sympathetic levels to near the parasympathetic levels, and your approximations are no longer available, are no longer appropriate. So what are you really measuring on follow-up testing? Whereas there are no assumptions or approximations with the mathematically complete method of parasympathetic and sympathetic, or PNS monitoring. And as far as PNS monitoring is concerned, like cardiac testing, if you don't stress the autonomic nervous system, you're going to miss most of the issues that patients have. Most doctors, when they assess you, you're at rest, you're sitting or laying down. And like the seesaw, it's only works on normal people at rest. So most of my patients, or most of our patients, when we start to see them, they've already seen a dozen doctors over a decade by the time they come to us. And you've had a dozen doctors working really, really hard to make you normal at rest. The problem is you're not normal. Your problems aren't when you're resting. Your problems are when the nervous system is active. And you have to realize the nervous system is arguably most active when you are resting. So that's the reason why a lot of people don't get relief. And again, the brake and accelerator model is valid in all states, especially the active state, whereas the seesaw model is only valid at rest. So back to the thermostat and the heating and cooling system. Let's assume it's a hot, humid summertime day outside, and your cooling system is working well, and the heating system heater switch fails, and your heating system comes on full. What happens to the temperature in the house? Nothing. Because, like I said, the cooling system is working well. It's going to amp up to compensate for not only the ambient temperature, but the heater being on. So everyone in the house who, assuming you don't have access to the heating and cooling system or can't hear it, only feels 70 degrees and thinks everything is fine until a catastrophic failure happens in one branch or the other. And then the temperature changes, but then it's too late. That's the heart attack, that's the stroke. And that's why there's still surprises. So simply measuring total autonomic function or measuring the temperature doesn't really help anybody. So after about 3 or 4 years of study and research on COVID and long COVID, including the vaccine injuries, this is what's going on. This is a very complex slide, I agree. So we'll break it into 4 or 5 slides. First thing we'll do is define these terms just right of at the bottom, just right of center: parasympathetic excess, sympathetic excess, and sympathetic withdrawal. So parasympathetic excess is an abnormal increase in parasympathetic activity in response to a sympathetic challenge, a stress of some sort, as modeled by the Valsalva or postural change or stand maneuvers that are typically used in autonomic testing. So think of the brakes and accelerator of your car. If you're at a red light and your foot's on the brakes and the light turns green, what's the first thing you do? You take your foot off the brakes. Most people say they hit the accelerator, but you first have to take your foot off the brakes, right? Because even before you hit the accelerator, you begin to roll. So without any additional gas, you're already accelerated. So taking your foot off the brakes minimizes the amount of gas, read that as adrenaline, and the amount of stress, read that sympathetic activity, that you're putting on the engine, read that your body. So if you don't take your foot off the brakes and you hit the gas, like a lot of people suggest, you still go, but you have to over accelerate in order to get to normal speed. And you're putting more stress and wear and tear on the car as well as the brakes. And the problem with the brakes in the human body is once they wear out, they cannot be replaced. So that's parasympathetic excess. And remember, the parasympathetics control and coordinate the immune system. So when the immune system is active, the parasympathetics are active. So a lot of people are with long COVID or vaccine injuries are basically trying to drive their cars with their foot on the brakes. To compound the issue, you get sympathetic withdrawal. Sympathetic withdrawal is one of the nervous system's responses to oxidative stress. It's an abnormal decrease in the alpha adrenergic or alpha sympathetic activity in response to head-up postural change, either sitting up or standing up, and as modeled sometimes by tilt table testing. It indicates orthostatic dysfunction. And then sympathetic excess, this is a beta adrenergic response, which is an excessive increase in beta adrenergic or beta sympathetic activity in response to head-up postural change. And in this case, it's a reactionary or compensatory attempt to get more blood to the brain, and it tends to indicate syncope. So the portion of the previous slide, the complex slide, that deals with the parasympathetic side, persistent immune activity causes parasympathetic excess, which exacerbates the persistent immune activity, and you get this vicious cycle going on, which can be broken, or you can prevent the parasympathetic excess leading to that list of symptoms that are directly related to the parasympathetics. Remember that parasympathetics uniquely control or coordinate the immune activity, hormone activity, and upper and lower GI motility. So these are some of the symptoms that differentiate the parasympathetic excess from the sympathetic dysfunctions. So with parasympathetic excess and persistent immune activity, you get this vicious cycle, which can lead to other symptoms that are considered the mainstays of long COVID and vaccine injury, including chronic fatigue, mast cell activation syndrome, and autoimmune like dysfunctions or disorders. It causes upper and lower GI symptoms, GERD, cramps, constipation, diarrhea, and eventually IBS, and maybe even Crohn's. It leads to autoimmune symptoms, mostly due to inflammation. It also causes hormone imbalance, thyroid, and especially reproductive, most effective in females. The estrogen, progesterone hormones that are affected by parasympathetic imbalance causes many women's health disorders all throughout their lives, whether it's menses, conception, pregnancy, or menopause. Normalizing parasympathetic excess actually helps normalize women's health and reduce the symptoms due to all of those things. It causes difficult to manage weight problems, and it exacerbates all the other symptoms that was on that previous slide due to inefficient cardiac function leading to decreased cerebral perfusion. So brain fog, sleep difficulties, memory, cognitive issues, headaches, migraines, etc., are all some of the symptoms that parasympathetic excess will exacerbate. Sympathetic withdrawal, this is your blood pooling in your feet. So even if you had the didn't have parasympathetic excess causing inefficient heart pumping blood to the brain, your heart would still have problems with sympathetic withdrawal because it's now trying to pump blood out of your toes as opposed to out of your abdomen getting blood to the brain. So it creates the list of symptoms here due to poor coronary perfusion leading to poor cerebral perfusion. Sympathetic withdrawal underlies orthostatic dysfunction, assuming your veins and the valves in your veins are working properly, and is the primary reason for POTS, orthostatic intolerance, or orthostatic hypotension, probably more specifically, which is the general issue, neurogenic orthostatic intolerance or neurogenic orthostatic hypotension, NOH, because you can still have orthostatic hypotension with normal sympathetic activity if you have damaged valves, but especially in younger patients, the problem isn't the valves and the veins themselves, it's the autonomic nervous system. Sympathetic withdrawal will lead to depression-like symptoms because your brain is hypoperfused. When your blood pressure drops a little bit further because of emotional or hormonal or other issues, you'll get anxiety-like symptoms cycled by the adrenaline storms the brain will send out to call for more blood. It causes temperature dysregulation because the alpha sympathetics control blood flow to the periphery. And so if you're not sweating properly, if your vasculature is not constricting or dilating appropriately, you'll have heating, temperature control issues, and it leads to wound healing problems. I mentioned sweat response, pseudomotor abnormalities, poor wound healing, and again, it exacerbates all other symptoms due to decreased cerebral perfusion, similar to parasympathetic excess in that sense. The sympathetics uniquely control or coordinate directly vasoconstriction, bronchodilation, baroreceptor reflex, and sweat glands. So this is why people sweat abnormally, may shortness of breath, in addition to palpitations when they're anxious. So sympathetic excess is actually a secondary autonomic dysfunction. It's typically in response to either sympathetic withdrawal or parasympathetic excess. The parasympathetic excess itself, however, exaggerates the sympathetic reaction. Again, your foot's on the brakes. Now you have to over accelerate. So parasympathetic excess is your foot is on the brakes while you're driving, and the sympathetic excess is the over acceleration of the car. Sympathetic excess is always secondary to parasympathetic excess. If you treat sympathetic excess directly as the primary problem, which is what happens most of the time because most doctors only see the sympathetic side. They don't know your foot's on the brakes. Blood pressure, heart rate, and cardiac output being high are sympathetic issues. Inflammatory histaminergic reactions, anxiety, pain, all of these things are sympathetically mediated. And the problem is if there's an underlying parasympathetic excess and you treat the sympathetics only, you essentially, as I explained to patients, your foot's on the brakes, you're having a hard time getting to 55 in a 65-mile-an-hour zone. Now your doctor wants you to go 45 only. And you're still trying to get to 65 because everyone else around you is going 65. And so you become exercise intolerant or more fatigued, or you don't react well to the medication, then of course it's your fault because you're not taking your medication. They don't see that your foot's on the brakes, they're treating the wrong thing. They're treating a symptom and not the cause. And as you know, if you only treat symptoms, it's like throwing a wet blanket on a raging fire. Eventually the blanket dries out, burns through, you need a new blanket. We're trying to control the fire. So sympathetic excess leads to exaggerated histaminergic reactions, which leads to unexplained allergies, including celiac disease and mast cell activation syndrome. You get grossly increased inflammatory responses, which leads to autoimmunity type symptoms, early onset arthritis, things along those lines. The combination of histamine and inflammatory reactions being amplified can lead to very abnormal menstrual cycles for women, either prolonged or heavy flows, including clots. It's that combination because the uterus is replete with mast cells, and those mast cells are being overactive. We'll get into that in a little bit. You get increases in blood pressure or heart rate like POTS. You get exaggerated pain responses. Little touches become very painful. You get exaggerated anxiety or anxiety-like syndromes. If you've been on anxiolytics or antidepressants for more than 9 months, you probably don't have a mental deficit. You have an autonomic deficit leading to poor cerebral perfusion. It can lead to difficult to manage blood sugar and other systems of the body. And parasympathetic excess is the vagal component of vasovagal syncope. Sympathetic excess is the syncope component as a compensatory response, and the combination leads to vasovagal syncope or preclinical. If you have the combination and you haven't fainted yet, you're basically going to eventually. So we try to treat you anyhow. So parasympathetic excess and sympathetic withdrawal are primary autonomic disorders that lead to poor cerebral perfusion. Sympathetic withdrawal exacerbates that by leading to poor coronary perfusion to begin with, and you get the rest of the symptoms that are common with poor cerebral perfusion that long COVID tends to incur. So parasympathetic excess and poor coronary perfusion leads to because the parasympathetics are essentially putting the brakes on the heart. So the heart is not pumping efficiently to the brain. And that leads to poor cerebral perfusion, which leads to depression-like symptoms, fatigue, including chronic fatigue, We've recently published a book on that. You know, it's entitled Chronic Fatigue, or Fatigue rather. Is it chronic fatigue syndrome or persistent fatigue? Since so many of our patients miss the chronic fatigue criteria, but are still fatigued, we've created this category called persistent fatigue, which allows us to treat anyhow, based on autonomic dysfunction. It includes lightheadedness, increased anxiety-like symptoms, sleep difficulties, cognitive memory difficulties, brain fog, frequent headache or migraine, difficult to manage heart rate or blood pressure, unexplained arrhythmia, palpitations and shortness of breath, increased resting blood pressure as another compensatory reaction, myoclonus due to the brain being half asleep and not keeping your muscles quiet, ADD, ADHD, or OCD-like symptoms as another compensatory mechanism, and exercise intolerance. Parasympathetic excess and sympathetic withdrawal together or individually lead to poor cerebral perfusion. Actually, anything above the heart is not getting properly perfused, so the additional symptoms of dizziness, whether it's central or peripheral vestibular, coat hanger pain, the pain between your shoulders and up your neck where your muscles are tight, again, calling for more blood, sensory, the cranial nerve dysfunction, vision, hearing, taste, smell, skin. If their mitochondria are not working well, plus the fact they're not getting enough blood, those nerves aren't going to work well. You're going to have vision issues and tinnitus or other hearing issues and taste and smell problems, as well as strange sensations in your face. So these bruised nerves, and I say bruised in quotes because they're bruised from the sense of their mitochondria are being affected, or they're bruised in the sense of not enough blood, so they're not getting enough oxygen and nutrients. Every nerve that doesn't function well essentially creates the sensation of pain, so the brain knows where the problem is. Or excessive spontaneous activation, such as in the auditory nerve or the vestibular nerves, where you get the sensation of dizziness or ringing in the ears. The compensatory mechanisms that the body tends to try to implement to compensate or prevent the poor cerebral perfusion before you faint. Remember, the ultimate is fainting. Now that you faint, you fall, your heart and your brain are at the same level, the brain gets all the blood at once. It's happy. You're not, but it's happy. Which, by the way, is why many people with these problems have sleep difficulties. It's not that you have insomnia, and you've probably taken plenty of melatonin and other sleep medications and only get mild relief. Well, if you're upright all day, your head's higher than your heart, sitting or standing, as soon as you lay down, your brain gets all the blood at once. It wakes up and wants to play. You want to go to sleep. Even if so if you take longer than 20 or 30 minutes to go to sleep, your brain, some patients tell us that their brains are more active when they're laying down trying to sleep than they are all day long. Well, that's because your brain finally got enough blood and woke up. The other is, even if you have to go to the bathroom more than twice, again, your brain is looking to play. It wants to go for a ride. It can get you out of bed by making you feel like you have to go to the bathroom. And as many of our patients tell us, they're sitting there the third, fourth, fifth trip to the bathroom, nothing happens. Well, of course, you're empty. Your brain is playing. You wanted to go for a ride. The problem is the next morning, all night long, you're sitting there making all these lists in your head of the things you could have done, would have done, should have done the previous day. You sit up the next morning, it all drains right out, as we're told by many of our patients. So cerebral perfusion is a main cause of most of the symptoms that long COVID and vaccine injury leads to. So to get more specific, with autoimmune syndromes, again, there may be symptoms of parasympathetic excess, especially the inflammatory variants whose autoantibodies are yet to be found. As we said before, the parasympathetics control and coordinate the immune system. Up to 60% of your immune system is not your own cells. Remember, they're borrowed from your mom on your way out, or they're swapped with all the playmates that she throws you in, those germ sponges she throws you into the playpen with when you're young. That's where you get 60% of your immune system. So if the parasympathetics don't cause these cells that are not yours to go dormant after the infection, they want to feed, they're hungry. And once the infection is gone, the only thing that remains for them to feed on is you. And this is promoted by the parasympathetic excess, which keeps them active. So if your immune system is feeding on you, is that not the base definition of autoimmunity? And it turns out relieving parasympathetic excess has relieved many of the newer autoimmune disorders that are currently being researched. Relieving parasympathetic excess can be done with low-dose anticholinergics or low and slow exercise, as we learned from colleagues of ours that actually work with NASA astronauts. NASA astronauts are arguably the healthiest people on Earth, and it takes them only 2 days in space for the hearts to become deconditioned because of the lack of gravity. And they can come back to Earth and run their 10 miles because their entire body is helping their hearts pump blood to the brain. That's not the problem. The problem is when they stop exercising and the heart has to deal with all the post-exercise recovery processes, that's when they crash. And they can crash for up to 3 days. And it takes them 3 months of low and slow exercise to recover. So it's going to take long COVID patients at least 6 to 9 months to recover. And that's assuming they don't have any flares or setbacks in the middle. So with these autoimmune syndromes, since it takes so long to treat the autonomic nervous system, we need to treat the inflammatory processes in the meantime. So those of you who are researching these autoimmune syndromes, especially if they're inflammatory autoimmune syndromes, please keep going. I'm not trying to take your job away from you. We need you to give these patients a life while we're trying to get their quality of life back. Mast cell activation syndrome. Again, mast cells are part of the immune system. The parasympathetics release the mast cells, and then the histamine is released from the mast cells by the sympathetics. So if you have parasympathetic excess, you're going to get too many mast cells released. And then the parasympathetic excess causes sympathetic excess. So with too many mast cells released, you're going to get too much histamine from each mast cell released. So now you have an order of magnitude increase in histamine release. This is where the unexplained rashes come from. A couple of weeks ago, we had a patient, they literally had this rash on their palm. They couldn't figure out what was going on. I asked them if they touched the doorknob. They said, yeah, I was at in a strange place and I touched the doorknob. I said, well, did it happen within a couple hours of that? They go, yeah, how'd you know? I go, well, that doorknob had something on it that you didn't like. So, it could be that simple. And going back to menstrual issues, this is where the too much histamine draws too much inflammation, which is also exaggerated by the sympathetic excess. So you have way too much inflammation. And it's that inflammation that's drawing all the extra blood. And that's why some women's menstrual cycles are very heavy and prolonged, because they have some form of parasympathetic excess leading to some form of mast cell activation syndrome. So you can relieve parasympathetic excess again with the anticholinergics or low and slow exercise. Sympathetic excess is relieved organically as the parasympathetic excess is relieved, but you might need to help that along in the interim. And then meanwhile, you need to control the mast cells with daily dosing of both H1 and H2 blockers. And that actually helps with the menstrual issues as well, by reducing and ultimately reducing heavy periods. POTS. POTS is just one of many autonomic dysfunctions. It's not the autonomic dysfunction, unfortunately, it's unfortunate it's being promoted that way. So POTS is a symptom of sympathetic withdrawal. The orthostatic dysfunction, the O in POTS, is an alpha adrenergic disorder. The sympathetic withdrawal that we've been talking about. Tachycardia, the T in POTS, is an excessive beta adrenergic response, and it's a compensatory mechanism to help cerebral perfusion. If blood is down in your toes, you have only two ways to get more blood from your heart to your brain. You either increase rate or increase pressure. Those that have physically smaller hearts, which tend to be younger women, they have smaller stroke volumes. They don't have the leverage to increase pressure, so they increase rate. That's the reason why POTS, for the most part, tends to be a problem in younger females. That's not to say, it can't happen in anybody, but again, it tends to be a stroke volume issue. So we relieve sympathetic withdrawal, we relieve the POTS, which includes relieving the tachycardia organically. Ultimately, even though we might need the beta blockers in between to help really maintain a bit of a lid on the tachycardia. Of course, we don't want to have the heart racing too much. We also use the antioxidant CoQ10 to help keep the heart energized if there's a significant amount of tachycardia going on, so that we try to keep the heart muscle itself healthy, as well as alpha lipoic acid, which helps to keep the nerves healthy. Alpha lipoic acid and CoQ10 are the two most powerful antioxidants your body makes naturally, and they're highly recommended for autonomic dysfunctions. Now, the problem with POTS, as far back as the 1990s, the autonomic leadership would state that 1/3 of all POTS patients have vasovagal syncope. The problem nowadays, the reason why the autonomic leadership is not promoting that much anymore, and they're actually saying that they don't understand what the cause of POTS is because they can't measure the two branches at the same time, independently. So POTS is a sympathetic withdrawal, vasovagal, vagal parasympathetic, syncope is a parasympathetic excess problem. So, and then the syncope is a beta sympathetic excess problem. So you have three dysautonomias going on all at the same time. And you have to treat the two primaries, the parasympathetic excess and the alpha sympathetic withdrawal, at the same time to relieve both POTS and vasovagal syncope, which I'm finding, or we're finding in long COVID patients, that ratio of vasovagal syncope to POTS patients is much higher than 1/3, probably closer to half. If the only way to document both POTS and vasovagal syncope is with PNS monitoring. Again, the others are only measuring total autonomic function and not the two individual branches. And you must treat both at the same time. So we already talked about parasympathetic excess with low-dose anticholinergics. Sympathetic withdrawal, you treat with vasopressors and fluids. Meanwhile, you do need to treat the tachycardia without it causing exercise intolerance. So again, the patient can have a life while we're trying to get them their life back. It turns out sympathetic withdrawal is one of the harder autonomic dysfunctions to eventually cure. It's one of the first that tends to present and one of the harder ones to relieve. We learned a lot of this from working with diabetics and Dr. Aaron Vinnick for many, many years, who was one of the godfathers back in the 80s and 90s of autonomic dysfunction and therapies. Before there were these vasopressors, alpha lipoic acid was the treatment for sympathetic withdrawal prior to the mid-90s. Fatigue. Myalgic encephalomyelitis or chronic fatigue syndrome may be a symptom of parasympathetic excess or sympathetic withdrawal. Again, poor cerebral perfusion leads to a half-asleep brain, and that's the fatigue that most people feel with all the other sleep, depression, etc. symptoms. So again, we can relieve parasympathetic excess and sympathetic withdrawal, and we relieve a lot of the fatigue symptoms that patients have, whether it's chronic fatigue or persistent fatigue. And as we said before, low-dose anticholinergics and vasopressors with fluids are the mainstay therapies. Meanwhile, you need to treat the symptoms, including inflammation, sleep difficulty, etc. And typical ones that we recommend that are not that do not interfere with the autonomic therapies are turmeric or curcumin for the inflammation, and SSRIs for the depression and sleep difficulties or even headaches. Affective disorders, including ADD, ADHD, OCD, depression, anxiety, etc., bipolar, and any of the other depression or anxiety type syndromes, again, caused by poor cerebral perfusion, caused by either parasympathetic excess and or sympathetic withdrawal. Further drops in blood pressure, as I mentioned before, cause these adrenaline storms, cycling, anxiety-like symptoms. ADD, ADHD, and OCD are also other ways to maintain brain activity to call for more blood. We've all been through mentally trying times, like a 2 to 3 hour hard final exam at school. You walk out feeling like you ran a marathon, but you sat for 3 hours. Remember, just sitting there doing nothing, your brain consumes 70% of all your body's resources. You go out and swim hard or run a marathon or something along those lines, your brain goes up to 85% of your body's resources. This is why mitochondrial health and oxidative stress at the cellular level is so damaging to the whole body, because you're starving your brain, and your brain is consuming all of your body's resources. This is why a little bit of a flu can wipe you out and make you feel tired, because the flu virus is robbing your body of the energy molecules that you need to function properly. So your brain's not getting the resources it needs to stay awake, and everything is, you're fatigued and everything feels worse. High blood pressure, heart rate, especially at rest, are other ways for your body to compensate for poor cerebral perfusion. Palpitations, shortness of breath, or other compensatory mechanisms. The shortness of breath, you feel short of breath even because your brain is screaming for more blood. It makes you feel like you're not getting enough oxygen in, so you feel short of breath. Again, relieving parasympathetic and sympathetic withdrawal helps to relieve these affective disorders, and you do that with the therapies we mentioned before. Meanwhile, again, we need to treat symptoms. We need to treat them in a way to not interfere with autonomic treatments, which tend to be homeostatic, very low dose. So treatments for all these disorders help patients to have a life while we get them a life by restoring PNS balance, both at rest and in response to challenges. PNS balance, restoring PNS balance may take up to 18 months. We need to make sure that our patients realize that. We have to set that expectation. You need to let them know that you're going to stand by them and work them through this. You're not going to desert them like many other doctors do, or disown them because you basically don't understand what's going on. We do, and we've had many successes over the years, including since the beginning of COVID. Once PNS, as well as COVID vaccine injury, sorry. So once PNS balance is restored, the remainder of any symptoms are actually true disorders, and these are end organ problems that you can then treat more aggressively. Remember, the nervous system has a memory, so once you restore that balance will remain there until some other clinical event happens that pulls them out of balance again. And then you got to figure out where that new imbalance came from and treat that appropriately. So in the meantime, like I mentioned, let's treat the symptoms to have a life and hopefully stay productive while we're trying to get them their quality of life back. And we usually look forward to discontinuing all the pharmaceuticals once the balance is reestablished, and leave them, if necessary, on supplements and lifestyle changes. All parasympathetic and sympathetic dysfunctions are treatable, and contrary to popular opinion. One of the first articles that two leading doctors published for us was just that autonomic neuropathy is treatable. Unfortunately, in the autonomic world, we have very poor nomenclature, and the thinking is neuropathy is not treatable because neuropathy suggests dead nerves, and we know that we can't treat dead nerves. That's not really what's happening, because as long as you feel pain, the nerves are not dead. The nerves are bruised, maybe, but they're not dead. We can fix bruised nerves. We cannot fix dead nerves. So it's all treatable, but it has to be low and slow. Think of the nervous system, the autonomic nervous system, like a swinging pendulum. If you hit a swinging pendulum hard, knock it off its hinge, you create many more symptoms. And that's actually what we saw when we saw our first couple of hundred fibromyalgia patients. Fibromyalgia is not actually a rheumatological disorder, it's an autonomic disorder, first of all. But the high doses of tricyclic antidepressants that these patients were on were actually causing most of the symptoms that they had. We took them from upwards of 200 milligrams of tricyclics because their pains were that bad, all the way down to 12.5, and some patients finally started feeling better. And at 10, almost all of them started feeling better and sleeping better, as well as having reduced headache and generalized pain. So this is another example of why it needs to be low and slow. Easy, small, gentle nudges over time is the way you correct a swinging pendulum. You don't hit it hard. And this is, again, why it can take up to 18 months. And if they have other disorders like diabetes or hypermobility that's pulling the nervous system out of balance already, it may be even longer than 18 months. But perseverance and even setbacks like heat stress last summer in the Northeast set almost all of our patients back a couple of months because the humidity was so bad, the heat was so bad, they couldn't get away from it. And they just had to persevere, stay on their low and slow therapy, and eventually it all took care of itself and they got back to feeling better. So the low homeostatic dose of the anticholinergic, as an example, no more than 10 milligrams of nortriptyline. We prefer nortriptyline over amitriptyline, even though it's the weaker of the two cousins, because it has less of a weight gain effect and patients tolerate it better. But it has to be 12 hours before waking, because it's going to pattern the sleep. If you take it at bedtime, it's not really going to help you. But if you take it 12 hours before you want to wake up, a lot of patients after a couple of weeks say that they don't even need their alarm clock anymore. They wake up refreshed. It gives you that REM sleep that you're looking for. It's not a sleep medication where it knocks you out. And then, of course, fluids and electrolytes to help your heart pump your blood by keeping water in your vessels. Sympathetic withdrawal is treated, again, low dose, homeostatic dose vasopressors. The primary treatment that we recommend is 2.5 milligrams 3 times a day of mitotrine, titrated from half a pill once a day in the morning up to 3 whole pills a day in 6 steps over 12 weeks. In the interim, we also treat the symptoms to help them be able to keep their heads up so that they're not dizzy all the time or lightheaded all the time. And then stress avoidance. Stress, if we go back to the original diagram, the other input to the whole system is this big red box that is labeled stress. Stress of all sorts, especially psychological, emotional, and mental stresses, because those you can't run away from, like PTSD, are the greatest adversaries of patients. And it gets to the point with parasympathetic excess that even healthy stresses, like exercise, heavy exercise, and food, can become bad as far as the body is concerned. And it's a protective mechanism. One example that I use with patients is if you think of, especially women, if you think of when we were cave people, The women, sometimes the women would have to stay back with the children in the back of a cave, trying to stay warm, sort of semi-hibernating, and they'd still have to wrangle the children and nurse the children while us guys were out trying to find the odd dinosaur to feed the family. It might take 3 to 5 days to come home with some food. And that layer of extra fat that a female tends to carry around with her, even at a normal weight, is a survival mechanism. It's what allows you to go through those 3 to 5 days and still have someone sucking milk out of you before you get to eat again. So in that sense, food becomes a stress because back then when our systems are not yet programmed to have a McDonald's on every street corner, or the amount of food that's available for most people, especially in Western cultures, tends to become a stress for people sometimes as well. But the bottom line is all parasympathetic and sympathetic dysfunction is treatable. Flares and setbacks, again, trauma, stress, greatest adversary. This is a diagram we borrowed and modified from the literature. COVID virus down at the bottom affects mitochondria, leads to oxidative stress at the cellular level, leads to those interim problems, which ultimately causes dysautonomia. And the list of symptoms on either side of the dysautonomia statement are these. And again, you got to treat it easy, low and slow, stay the course, even through a setback, and you don't knock the pendulum off its hinge. So these are some of the recent articles that we published on long COVID, which the long COVID concept works for vaccine injuries. And this will give this should give hope to those who are out there suffering, showing ways of being able to treat it and what it takes to try to cure it. The illustrations were borrowed from these websites. We thank the websites. So if you have any questions, comments, thoughts, criticisms, we are happy to engage. Thank you.
Wow, thank you so much, Dr. Colombo. That was an amazing talk. You somehow put together what so many of us are experiencing in 1 hour, and we've been searching for several years, trying to make sense of this and not really being able to get good explanations from our physicians. So thank you. That was so amazing. So let's see, we have a few questions in the question and answer box. The first one is, please give examples of low and slow exercise.
Right. So the maximum exercise we recommend for our patients with their heads higher than their hearts is walking at no more than 2 miles an hour for no more than 40 minutes. Remember, this is a manageable stress that we're introducing to the nervous system to essentially break the bad habit of everything is a stress. So the rest of the stresses throughout your day, you may not have control over. If you're a mother chasing after children, having to deal with a household, maybe working at a job where you don't have a lot of control over what's going on, those stresses you can't deal with. But this is a manageable stress that you can introduce on a daily basis to try to retrain your nervous system and break that bad habit. So that's the maximum. Swimming is great, but don't use arms and legs at the same time because more muscles, more stress. The best is actually, especially in the heat coming up with summer in the north, if you get about an inch over your belly button in the shallow end of a pool and walk around for about 40 minutes, nice and slow. Keeps you cool and gives you that exercise and get a little bit of negative pressure from the water to help move the blood up to your abdomen. Your heart pumps easier to your brain. Biking, especially reclined bicycles, pedaling. Just again, you're not racing. It's got to be a slow pedal, like you're walking at 2 miles an hour. Rowing works. Pilates is usually more stress than we recommend. Some yoga yoga exercises, that's the word I'm looking for, can help as well. On the bottom end, on those days where because of the other stresses, or maybe you felt really good and decided to see if you can exercise harder, and you're wiped out the next day, the minimum stress, the minimum exercise rather, is you lay flat on your back with your bottom up against a table or a chair, where your legs and knees, lower legs and knees, can get up on top of the chair or table. Sort of like those upside down bicycle exercises we did as kids in gym class at school. And then you just kick your lower legs like you're walking at 2 miles an hour. That'll get blood out of your feet, down to your heart, up to your head. You'll tolerate the exercise. And believe it or not, even for the astronauts, that was the minimum exercise needed to recondition the heart. So some form of those exercise for up to 40 minutes. That's the caveat. You know, that lethargy, as I call it, that resistance your body runs into after 5, 10, 15 minutes of exercise, where your body doesn't want to do it anymore. You need to listen to that. If you can gently work through that, you're helping to break the bad habit. If you feel you're bullying your way through that because, damn it, I'm going to get to 40 minutes come hell or high water, then you're actually causing more stress, and that's not helping you that session. So some days you might get to 40 minutes. Some days you may only get to 5 minutes. That's okay. You need to listen to your body, because stress is the bigger issue, not exercise.
The next question is, I am very skeptical of what I read about the skin disease prurigo nodularis, said to be a neuroimmune disorder, not an autoimmune disorder. Any comment?
Well, either way, the immune system is activated or overactivated. And if it's COVID generated, it's the parasympathetic excess that's underlying it. So it is neuro and it is immune. Whether it's autoimmune or neuroimmune, I don't know. And I don't think it much matters from a therapeutic point of view.
Okay. And the next question, what about digestive and GI issues? I guess.
Right. So parasympathetics control your GI tracts from about a third of the way down the esophagus down to just before the rectum. Parasympathetic, more parasympathetic activity increases GI motility, less parasympathetic activity decreases GI motility. So by time most GI tests look for blockages and holes. By the time you have blockages and holes, your motility hasn't been normal for a long time. Unfortunately, gastric emptying studies are the only motility studies that are currently available. There are others that are being worked on. There's several groups that I work with that are looking for more motility measures that are more specific to the GI. But autonomic testing, if you have parasympathetic excess, you probably may go back and forth between too fast and too slow, because when you're at rest, you're really resting, and your GI tract will be moving too fast, and you'll tend towards gastric dumping and or diarrhea. And if you're stressed and the sympathetics are dominant, reducing the parasympathetics effect on the GI tract, you'll have more gastroparesis-like symptoms and stiffer stools and constipation. And if you swing back and forth, again, it's not IBS, it's parasympathetic excess, because you're going back and forth between being overstressed and being over-relaxed in a sense.
The next question, can you give some good examples of H1 and H2 blockers?
Zyrtec and Pepsi, over the counter, whatever brand you want, just follow the box. 90% of our patients, that works.
Right. We have a lot of questions, so I'm not sure if we can get through all of them. Do you have a little more time?
Yeah, but again, remember, we've got the website that I mentioned has a question an area where you can give us your contact information, ask your question, and
Okay.
somebody will get back to you.
Let's see. I'll just get through as many as you can stay with us for. Is it true that you can't use alpha lipoic acid if you have mercury amalgam fillings?
Not to my knowledge.
Okay. Sam M says he's beyond grateful for this presentation, crying while listening to this because it hits so close to home. Looking forward to rewatching in order to take it all in even better. Thank you all for this. And I echo his sentiments.
And I'm glad you recorded. We actually let patients record our sessions in clinic because we do understand brain fog.
Yes. What are the best beta blockers?
For POTS, especially younger patients without cardiovascular diseases to begin with, go with the weaker ones. Propranolol usually is our go-to. Nadolol or atenolol are the ones that, if they don't respond to propranolol typically for allergic type reasons, we will go to those. But the weaker ones, the stronger ones create too much fatigue, exercise intolerance. And as we're treating the underlying cause anyhow, it eventually goes to PRN and then they come off. PRN being as needed.
Tejal says, fantastic presentation. What are your rehabilitation recommendations for shortness of breath, exercise intolerance?
Well, it depends on what the underlying autonomic dysfunction is. If it's long COVID, it's probably both parasympathetic excess and sympathetic withdrawal, and you need to treat both. So the treatment recommendations are in the presentation.
Kathy is asking, how do I know if I have SW or PE?
Unless you can get to a place that has the ability to test both branches, if you know it's long COVID or if you know it's vaccine injury, then you can make that assumption. If you don't have access to someone who can write you the prescriptions for mitogen and nortriptyline, alpha lipoic acid and low and slow exercise don't require prescriptions. So fluids, electrolytes, low and slow exercise, and alpha lipoic acid with some CoQ10 if you have POTS is going to be the mainstay of your therapy, and you just need to let it take its course, and it'll eventually work for you.
Carrie asks, I am being treated with beta blockers alone. Will that help reset? Also, any ways to help with sleep?
Unfortunately, beta blockers alone is only treating a symptom and actually may interfere with your body's attempt to naturally relieve your vaccine injury or long COVID symptoms. Remember, the tachycardia of POTS is your body trying to get blood out of your feet up to your head. You reduce that ability, your body is going to find a way to defeat the therapy. And the sleep problems, again, if your head's higher than your heart most of the day, sitting or standing while you go through your day, as soon as you lay down, your brain gets all the blood it wants. It wakes up and wants to play. You want to go to sleep. So one thing you can try to do about 2 hours before you want to sleep, if you lay down or even go about 15 degrees head down posture, and you let gravity do what your nerves in your legs aren't doing for you. You get blood out of your feet down to your head. Don't lay there for more than 20 minutes, because then your lazy nerves in your legs will stay lazy because gravity is doing the work. Also, if you have head pressure of any sort or more headache when you're laying flat or laying head down, you need to at least put 2 pillows under your head, because head pressure is never a good thing. And that'll get blood to your brain. It'll wake up your brain, and you'll go through the normal day to night conversion that happens between 8 and 10 o'clock at night. And if you do this at 8 o'clock, your brain will be ready to go to sleep at 10 o'clock when you are, hopefully. And you should get better sleep that way. Well, if you can get the nortriptyline, well, the rest of it's working, or the midodrine. That's an interim solution that we help people start sleeping sooner than the medications tend to create. May still take a week or 10 days for it to really kick in, but most patients find that that's helpful in the interim.
We'll do a few more and then we'll let you go. So have you ever recommended Qigong? I hope I'm pronouncing that correctly. I recently tried it and finds it helps clear my brain fog. There are many beginner videos on YouTube.
Yes, I actually work with a number of traditional Chinese medicine practitioners. We don't know exactly why Qigong works. We do know that it does work in some patients. So if it's working for you, great. Don't understand the long-term effects. Most things that help people along those lines try to chemically work with the brain, which we ultimately rather work by restoring proper blood flow to the brain. So at least as an interim. And then the other is most traditional Chinese medicine practices actually affect the vagus, the parasympathetic side. So again, it may be a short-term relief because your parasympathetics are already overactive, and if this is stimulating the parasympathetics to help you sleep more, you already have a problem with an overstimulated parasympathetic nervous system. So it may work for a while and then may stop working, and that would be the reason why.
Do you have an explanation for persistent pericarditis? I take turmeric and up to 2,400 milligrams of ibuprofen per day as needed with flares. This is my 6th flare after COVID vaccine injury.
So you're treating the inflammatory side, but the inflammation, again, the inflammation is being treated like a wet blanket on a raging fire. The parasympathetic excess is augmenting the sympathetic excess, which is exacerbating the inflammatory response. So even your high levels of inflammation and anti-inflammatories like turmeric is only sort of nibbling away at the edges of the problem. And then if you compound that with not enough blood flow to the heart to begin with, the heart is having to overexert itself while being inflamed. So this is the problem with just treating symptoms. Ultimately, you got to get to the underlying causes of parasympathetic excess and sympathetic withdrawal.
Let's see. Also, if symptoms persist, what do you mean by treat more aggressively, since many of us still have symptoms?
Assuming the nervous system is back into balance, now we know that the nervous system is not telling the organ the wrong thing to do at the wrong time. So it's the organ itself that has some sort of dysfunction. So once the nervous system is in balance, we figure out what the remaining dysfunction in the organ system is, and then you can treat that more aggressively because you're not fighting the patient's own body. If, like for instance, if the patient has orthostatic hypotension, blood pressure is dropping when you stand, if the patient's resting blood pressure increases to try to compensate for that, your doctor sees only the increase in blood pressure and not the orthostatic dysfunction because he's only assessing you while you're at rest, then he's going to treat the high blood pressure. Well, the blood pressure is high because your brain is calling for more blood all the time. He's going to lower pressure. Your brain's not going to like it. Your body has 7 pathways by which to control blood pressure. Medicine only has 3 or 4 ways of blocking those pathways. So the body still has 3 other pathways to defeat the therapy. But if you normalize the nervous system and your heart rate, your blood pressure rather, remains high, now you have primary hypertension, which is the basic assumption. And now we can be more aggressive and usually lower dose in treating the hypertension because it's actually going to work and you're not fighting the patient's own body.
Right. There's so many good questions here, and I think some people are going to have to ask you individually on your website. And could you just give us again your websites? People are asking. I put it in the chat. But
So it's Physio PS, P as in Paul, HY, S as in Sam, IO, P as in Paul, S as in Sam, .com, physiops.com. Actually, the good questions that you see, if you want to email them to me, and I'll give you answers so you can post them so that everybody gets a chance to see them.
that would be wonderful. But can we do a couple more and then we'll let you go? So are you ready?
Yeah, I have about 5 more minutes.
Okay. So once our nervous system becomes imbalanced and we go into remission, why is it so easy to relapse into imbalance? And 3 questions here. What are your thoughts about spike protein toxicity and microclots?
Okay. So if you go back to the thermostat analogy, all the stresses of your life, your nervous system, well, let me back up again. I'll start over again. I'm sorry. Your nervous system's job is to maintain normal organ function, even if itself is abnormal. So again, think about the thermostat analogy. If your heating and cooling system are out of balance, you still may get to 70 degrees. You know, your cooling system may be cooling things down a lot because your heater is on. So both are working high, but the net result is still 70 degrees. The nervous system will maintain that level of function as long as it can until it fatigues. And when it fatigues, you're going to wind up with symptoms. So if your nervous system is constantly under attack because of the different stresses in your life, it's going to be pulled back out of balance. And if you're not actively monitoring it and working to keep it in balance, you eventually get to that straw that broke the camel's back concept, where you'll have another flare and you'll have another setback. So that answers the first question. Spike proteins, they're proteins. They're parts of the virus. Whether it's a protein, a portion of the virus, or the entire virus, your immune system still has to deal with it. So any portion of the COVID virus, or any virus for that matter, that is introduced to the body, the immune system gets active, the parasympathetics get active, and if it's a serious enough infection, you get this parasympathetic excess that leads to the constellation of symptoms that we presented. And then what was the third?
The third one was questioning about microclotting. In this instance, in the eye, but microclotting is, a theory that
Yeah. So
we're talking about.
what we learned from critical care medicine is parasympathetic excess is also in response to pre-septic kind of states. So when the microvasculature starts to clot, certain areas of the areas of the body that are associated with those microclots are not getting appropriate oxygenation, appropriate blood perfusion, and the parasympathetics are exquisitely sensitive to those situations. So microclots is a big deal. It's another cause of parasympathetic excess. And since COVID is known to cause these microclots, that's the body's attempt to somehow restore proper perfusion to that area of the body.
I think we'll end here. I will send you the other questions. And where can we look for the answers on the website, or?
I'm going to send the answers back to you and you can post it on the React 19 website.
Excellent. That's great. Well, I want to thank you very much, Dr. Colombo. This was just a very enlightening talk and really made sense of a lot of things that we've been suffering from. And I want to thank everyone for joining us and for giving us such great questions. And I hope everyone gained some information from this. And I will post the talk as soon as it is available, and I'll post the answers to the remaining questions. So good night, everyone. Thank you so much.
Good night and take care.
And by the way, this is Denise Hertz. It says I'm Bree Dressen, but I'm not. Bye-bye.